Hello, everybody. Very nice that you entered our live stream on this nice Tuesday afternoon. My name is Dr. Kai. I'm a radiologist from Berlin, and I'm also running BerlinCaseViewer together with my team. And today we have a session that brings you into the very small details of arthritis imaging. And I hope that you will learn a lot. I prepared 5 cases and also will review a short lecture. So before we start, and also to reduce my nervosity a bit, please comment where you are from, where did you join, from where did you join, so we know what's going on, and maybe also you can tell me if you are a beginner or an advanced radiologist or student, so that I can tailor my lecture according to you as the audience. So that would be nice. I also have a long-time fan here in our show today. Hermann from UK and France is here. Very nice. So let's start. So I will have like let's say 10 minutes, maybe 12 of slides, prepared slides that bring you an introduction to the arthritis imaging. And then we also have cases that I will present that you can enter and that you can try to solve with our interactive platform. So we have, arthritis is difficult, that's for sure. So we are doing it on a regular. So hopefully we can bring some of the arthritis imaging spirit over to you today. So starting with the lectures, I'm starting with some beginner slides. Usually I advocate that when you enter the field of arthritis imaging, you should not be overwhelmed by the many different diseases that we can see on imaging of the hand and feet. So today we will speak about X-rays of the hand and feet, but of course, if you perform ultrasound, CT or MRI, you will see many more changes and diseases very early, and sometimes it's very difficult to come to a good differential diagnosis. So the trick is at the beginning to do not start with the diagnosis of the single joint or the single patient, but to get an idea if it is an inflammatory change or a degenerative change. So this is the major differential at the beginning. So you make the distinction, is it a degenerative change or is it an inflammatory change? And after you've done that, you can sort out the different diseases in that category. So the different inflammatory joint diseases, comparing it and giving the differential. And then if you know it's a degenerative change, then you can go to the different degenerative changes, because there's more than just osteoarthritis. In fact, we are making the distinction between synovial-based diseases like rheumatoid arthritis, enthesial diseases like psoriatic arthritis, and cartilage-centered diseases like osteoarthritis. And they all have different pathophysiology and therefore also present with different features on X-rays. So let's start with osteoarthritis. Osteoarthritis, of course, is a disease of the cartilage, seen here in blue, nice and smooth, and allowing the joint to function. This very regular architecture of the cartilage, the calcified cartilage over here, the uncalcified cartilage here, that's the surface of the cartilage. And over time, the cartilage gets damaged. We have destruction of some parts of the cartilage. We have fissures and also proliferations of the chondrocytes that are leading to an inappropriate architecture of the cartilage, and thus are leading to further changes in the bone. So the healing mechanism in the joint is the new bone formation beneath the cartilage. It's a subchondral sclerosis that will develop. And subchondral sclerosis is one sign, but of course the cartilage is now much thinner than in the normal status of the cartilage. So there is a reduced joint space. We call it joint space narrowing. And of course, this leads to a very unstable joint with no dense fibers in the capsule of the joint. So we have osteophytes that we can see at the edges of the joint that will somehow stabilize the joint and ease the pain, but of course they reduce the range of movement. And then there are also cystic changes that we can find in osteoarthritis, and these are pressure-related cavities in this spongious bone subchondrally. They are filled by small fissures, and there is joint fluid, synovia, and dead cells, detritus, that are going into these pseudocysts. And with these findings, you can actually diagnose osteoarthritis on almost all joints. Here's an example of the finger joints where we see different examples of subchondral sclerosis, of joint space narrowing. Here we have different examples with cyst formation, different sizes of cystic changes, and here's a lot of osteophyte formation, and here is an example, there's only minimal osteophyte formation and asymmetric joint space narrowing. You can also use it at the hip joints with different, so somehow my screen share sometimes breaks. You can also use it at the hip joint with different amounts of joint space narrowing, cystic changes, complete bone on bone, joint space narrowing, large cystic changes and sclerosis, and of course also osteophyte formation in similar processes can be found in the knee. Looking at rheumatoid arthritis, the synovial-based disease, and in the synovial-based disease, we have a proliferation of the joint capsule. That's the inner lining of the joint capsule. And this proliferation looks like this. If you're an orthopedic surgeon and do an open joint procedure, which is nowadays rarely done, and we call it pannus or synovial proliferation or pannus. And this pannus goes into the joint and is especially prone to go into the joint at the edges of the joint, at the bare areas where we don't have cartilage coverage of the bone and the joint capsule is not yet attached. So here we only have a thin layer of periosteum, and therefore it's very easy for the pannus to grow into this area and to lead to bone destruction. And this bone destruction, then we call marginal erosions because they are at the sides of the bone. So these erosions at the edges of the joint, and pannus is the reason. So if we use this drawing and translate it to an X-ray, we can see there are some erosions here at the edges of the joints with well-preserved joint spaces. And there are usually multiple joints affected by these erosions. And that's actually the major findings that we want to tackle today in our session. Looking at the feet is very important. So I see a lot of rheumatologists referring the patients for X-rays of the hand, sometimes even only of the wrists. And they're leaving out the feet, and especially in early disease, sometimes the feet are much more and much severe much more severe affected compared to the hands. This is a patient with MCP wrist and wrist pain. MCP joints were quite normal, but at the MTP joints, we could also already see large erosions at the MTP joints of the fifth ray and also of the fourth ray in on both sides. And actually, this is already bringing us to the topic of today's session. So here we see you need to compare the normal contours of these bones, and you need to know these contours in order to make the right decision. So here the MTP head of the second ray is nice and clear. But here already we see some small cystic changes, and maybe if you could enlarge it here, maybe even some subtle irregularity of the cortex. And here there are larger erosions. Also in this example here, there's bone that is missing. So if you compare to this second MTP joint, this piece of bone is not here. And these are the subtle changes that we want to discuss today. Usually in the feet, the lateral sides are more pronounced affected in rheumatoid arthritis compared to the medial sides. That's a rule also to remember. So looking at X-rays of the hand and feet in a follow-up sequence is something that is not very well liked by us radiologists. Maybe rheumatologists are much more into that. So you can see this is a baseline X-ray and a follow-up after 2 years. And you can see that you need to have very good quality X-rays in order to compare. Looking here at the second joint, looks normal. Now we have cystic changes here, maybe some early erosion over here. Here we already had some severe destructions with erosions leading now to subluxation and cross destruction. This joint more or less is stable. And here, the fifth MTP joint, we see some small cystic changes. I don't know if you would call these in your report, if you would mention those, but you can see 2 years later, these precursor erosions are now full erosions, taking away the bone and destroying this joint. And similar changes also here on the other side. So this is really something you should be aware of, that these cystic changes might play a role. Looking at the hands, here's a nice example. I think some of you might be aware that the left side is affected. It's not very easy to see, but if you compare the MCP joints of the right hand with the left hand, you can see there is some bone destruction over here, maybe also some joint space narrowing. Let's enlarge it a bit. So you see that's the normal joint space, about 2 millimeters, maybe 1.5. And here it's only 1 millimeter or 0.5 millimeters. So the joint space is narrowed. And also comparing the head of the metacarpal bones, you see there are cystic changes over here with irregular contours of the bone here. It's not a very sharp image, but I think this is an early erosion. And then we are talking about oblique hand projections here that we are usually trying to do in the early phase of the disease. And you see on this, my God, no, please excuse me for this glitch. So we are performing oblique projections in the early phase of our arthritis workup. And we can see in these oblique projections that the joint space is really narrow. And we see also here the destroyed cortex. So here it was not very clear, but here you could see the cortex does not go all the way here. So there's an erosion over here and even a cystic change in this third MCP head that you could not see here. But I know, I mean, maybe Germany is the last country who does these oblique projections. Even in some instances, we are now leaving them out. And the art of X-ray interpretation is now to detect everything on a posterior-anterior projection. Cysts and cystoid lesions have a very broad differential diagnosis, so they can occur in rheumatoid arthritis, but also in osteoarthritis, detrition cysts, I already mentioned them. And there are a lot of more diseases where cysts play a role. The list is very long and didn't even fit onto this slide. So what is the special special thing about these cysts. So looking at a 50-year-old woman with a normal looking AP projection, maybe there's a small cyst over here, a small lucency in the oblique projection. You see this lesion over here with some slight sclerotic rim. And then there's this other 47-year-old woman, similar pain, similar X-ray. Now we have larger cystic areas over here, maybe here as well. And in the oblique projections, it looks more or less similar to this one. And performing a CT scan of both of these patients. So this is like a small ganglion cyst or a geode. So it's fully covered by cortex, by bone, in multiple projections. And here's another example where we can see this is a larger defect in the bone. And we have here in the second MCP joint already a cortical break, which makes this an erosion. And we did publish this quite some time ago, looking at the axial reconstruction here. You can see there is some large erosion in both MCP heads. So these cystic changes, if you see them either in the posterior antral projection or in the oblique projections, they are important because they are not giving you the full proof that there's an arthritis, but they give you an early sign that maybe you perform an additional MRI scan or ultrasound of these joints because they are at risk for erosive damage. So here also geodes is a term that few people are aware of. The geodes are intraosseous destructions, and you can see them in arthritis patients, but sometimes also in patients with osteoarthritis. Here you see a defect in this wipe sequence in the third MCP head, where there is a cavity, but more or less no enhancement. Nevertheless, this is a patient with rheumatoid arthritis. You see there is some synovitis over here in this PIP joint on the second ray. So geodes are some features of arthritis that you should take note of. Finally, looking briefly at the psoriatic arthritis. In psoriatic arthritis, we have inflammation outside of the synovial membrane in the joint capsule and collateral ligaments. We have inflammation in the antitheses, as we call them, the attachment sites of the ligaments to the bone. Due to this anterior inflammation, we have also osteitis and enthesitis in the bone itself. And this then leads to new bone formation, and new bone formation not inside the bone, but at the edges of the bone, especially at the lateral areas where we have new bone formation, or that we call it periosteal calcifications and proliferations. That would be the term here in Germany. And later on, we also have secondary synovitis with bone destruction and marginal erosions. So that means in psoriatic arthritis, we have a combination of osteoproliferation and osteodestruction. So that means this is a completely different picture seen here with these defects in the bone and these ill-defined bone margins in a patient with severe psoriatic arthritis. However, also not in long-standing psoriatic arthritis, this picture is no longer visible, and it's very difficult to distinguish psoriatic arthritis from osteoarthritis on the long term. All right. So it's not my day today. So this osteoproliferation is due to osteitis in the entire bone, and you see osteitis can be visualized by MRI. You see bone marrow edema, usually affecting entire phalanges and also the periosteum. So I think at this time now you're prepared to look at images like these, where you need to compare the right side and the left side, where you need to look at the edges of the bone to see that this is the normal contour of the bone, of the ulna, of the radius, of the carpal bones. And here you see the periosteal new bone formation with ill-defined cortex, with fluffy contours, with periosteal new bone formations at many parts. And I think this is also now the point where we go over to our interactive cases. So I'm looking at the comments. We have some greetings from Turkey. So hello from Germany to Turkey or Turkey. We also have a comment by Hermann about the oblique projections. Oh, you also do oblique X-rays. That's very good. That's very good. So the oblique projections, in fact, they are they can be done in different in different. Do you have a book here? Something like this. Yes. So if you have an X-ray detector, that's my X-ray detector. Usually, if you do a posterior anterior projection, that's easy. You place the hand here and try to make the X-ray. You should pay attention not to make the fingers close to each other. You should spread them a bit, and also you should not do both hands on one film. You should do just one hand and then the other hand, which gives the better image quality. That's what you can see in today's session. And for the oblique projection, there is this theta player position. That means all the tips of the fingers, they are on the plate, and the fingers are bent a little bit to the side. And this position is called the theta player position. And this is more or less ancient musical instrument with a lot of chords and strings, a lot of strings, where you play the zither with the hands in this shape. And then the people from Scandinavia, they do Norgard position. Norgard position can be done, usually is done like you flip the hand and have the 45-degree position, and then you have a similar option to make oblique projections. So hopefully, Imane, you do it in the zeta player position. I don't know how you do it. All right. So I have now cases. I have cases that you can access yourself with. How can I get this? There's a QR code. So you can scan this with your phone, and then you are on our BerlinCaseViewer platform that I set up just for this session. I also will send the link here into the chat, so people who don't scan can still copy it. Give me 1 minute. And those who just entered, maybe you can also comment where you are from. That would be nice. So this is the link for you, and also I can put the link here as a banner, so you can see it on my screen. All right. So this is the link. You enter the platform. That means it will look like this one. Okay, so it will look like this one when you start it. So that's the welcome screen. You enter your name and email and click on Join Now. That's all. And also, then after you've done this, you will be in our platform that looks like this. You have the subtle findings collection. These are 5 cases, and we will now go through these 5 cases in the next maybe 60 minutes. And the first case is the most difficult one. And yeah, let's see what we can make out of it. So I'm inviting you to join and to look at the cases yourself. So the cases 3, 4, and 5. Oh no, the cases, the cases 4 and 5, they have a multiple choice question, so you can challenge yourself. And the cases 1 to 3, they don't have a question, so I will ask you in the chat, or you can answer in the chat, and I can show the result to all of you. So looking at the first case, you can see, okay, I need to share it. It was not visible. So these are the cases, 5 cases. So case 4 and case 5, they have a multiple choice question, so you can answer the question and we will see the results later. And here we have case number 1. That's quite a long case. And I will present this case to you. So this is, at the time of first presentation, a 59-year-old woman who had pain in her MCP joints already for about 2.5 years. And especially she was having problems when she opened the door, when she had a cup of tea in her hands and did other household procedures. CRP was slightly elevated. Rheumatoid factor was positive, and also anti-CCP antibodies were positive at that time. So that's a strong indicator for rheumatoid arthritis. Also, the age is very typical for rheumatoid arthritis, and the pain pattern as well. So looking at the image, first presentation from 2009, and it's always advisable to have both images together, to look at both images together. So here we see the left and the right hand, and we also have the oblique images that we can look at here. But let's first start with the posterior anterior images. And when I approach these images, I always go joint group by joint group. That means I first focus on the DIP joints, then I go to the PIP joints, MCP joints, later to the wrist and the radiocarpal joint. So the DIP joints here, they look normal. The PIP joints, they maybe have smaller cystic changes, but I would not overreact when I see these kind of changes. MCP joints, the first MCP joints looks very nice. Second MCP joint, I don't know if you have seen it or if you commented on it, doesn't look so nice, because if you look closely, you see there is some cystic area here, and also the cortex that we would expect here is broken here. You see that the cortex should look like this, should go smoothly here, and this is not the case here. And also this round shape is not here, so it's irregular, and there are maybe some cystic areas. And if you compare with the opposite side, that's not helping here, because you also see some smaller cystic changes. And here this looks quite good, but there's this density difference. So there is this low density area, and here it's higher density of the bone, and maybe there are some smaller cystic changes. So that would be in my report. I would say, yeah, that's a suspicion of an early erosion, and I cannot rule out more erosions here at the head of the metacarpals. The wrist itself looks good. And we can look at the oblique images, and if you do this, you will be surprised what you can see, because you see that this is the normal bony contour, but here we have a hole. That's a defect in the cortex. So there's no cortex here, but it should be there. So in fact, this is the evidence of an erosion. So on the AP it's different, but on the oblique it's clearly visible. And also if you compare it from the right side, if you look closely here, then I think you can see the erosion as well. So we have here the cortex, and it's a slight indentation. So it's not really clear that this is an erosion, but you see something else. I think I should have rebooted my PC. It was on several days. So you see the normal joint space, about 2 millimeters. And here we have almost bone on bone in the oblique view. So we have a joint space narrowing. We can also appreciate it here, that that's the normal joint width, and that's a little bit smaller, but on the oblique view, you see clearly that there's some joint space narrowing. All right, so looking at the left hand, we have then the follow-up 2 years later, and you can see that already 2 years later, we now see clearly that the joint space is gone. There's bone on bone here. And in order to search for bony destruction, I guess we would need to look at the oblique images. And it's not so easy to see. But maybe there's also some cortical breakthrough. I'm not sure here in this particular case. Okay. Looking at the right side, I think I need to refresh this one. Looking at the right joint, also on right hand, we can see that the subtle cystic changes here and the subtle joint space narrowing, also the soft tissue swelling, has now progressed to more pronounced destruction in the bone. You can see here you could have some doubt, but now you see these cystic areas here clearly represent severe bony destruction. And then you can follow up this for many years. Here it's more or less similar, but then after almost 9 years, joint space narrowing. And you can also see that the erosion somehow has stopped from progressing to mutilation, so it's well preserved. And if this patient would come to you for first evaluation, because there's a change of department, or the patient has moved to a different city, has now a new rheumatologist, and you do the first evaluation, the older films are not there, then it would be difficult to say this is a rheumatoid arthritis. And then you can look at the case, finally, many joints are affected. And what I wanted to demonstrate is especially the progression from 2023 to 2026. And if you now take a closer look to the styloid process on the right, you can see, so here it's the joint space narrowing, erosions. But the styloid process somehow has survived all the years, looks normal. And now this is no longer the case. We have now severe bony destructions. We have here now soft tissue swelling. We have destruction of the bone, and we also see the carpal bones, the capitate, the lunate, who have large defects that were completely normal three years ago. So this demonstrates a little bit the challenges that we face in our attempt to diagnose arthritis timely and early. So do you have any questions regarding this first case? Is there any comment? Yeah, there's one comment. Osteopenia. Yeah, osteopenia is such a difficult thing to discuss on digital X-rays. It was very clear on film-based X-rays, and now with the post-processing capabilities of modern X-rays machines, the osteopenia is very difficult to evaluate. So here we see more or less normal density of the bone, normal looking bone. And if we go to a later stage, maybe we can use this one here. Also here, the density of the bone is normal, so there's no osteopenia here, I would say. Also, my criteria is to search for the sponges pattern. This is quite looking quite good here. Also, the cortex is quite thick. And then at the end, maybe still, I'm very reluctant to speak about osteopenia, because also this osteopenia, if you say you have a patient with osteopenic or MCP joints, in my opinion, this is not sufficient to raise the diagnosis of rheumatoid arthritis. It's too weak. I would need a different pattern, like some small erosion or some cystic changes that are, in my opinion, much more helpful than osteopenia close to the joints. All right, any more questions? Not yet. So we will continue with the next case. So next case is case number 2, and I will go back, and you can also do it. Case number 2, pain with progressive right hand and wrist pain. So that's the left hand. We would also need the right hand. And the medical history is a 67-year-old woman with progressive pain at the right hand, with weakness, reduced grip strength, increased stiffness, CRP normal, lab tests all normals, no elevated inflammatory markers or antibodies. So when you see such an image, what would you say? You do the same pattern analysis. You start with the DIP joints. You do some enlargements maybe. Go for the DIP joints. They look good. They have normal joint spaces. You can go for the PIP joints if they have normal joint spaces. Then you go to search the MCP joints. Joint spaces look good, more or less. And then you look at the wrist. So is there anything seen? Please write a comment. Someone needs to write a comment. One. So criteria for erosions are you see the cortical break. But of course, I just demonstrated some examples with decreased density, and the cortical break was not clearly seen. So it's a bit fuzzy to decide when you it's also some experience. So it's the exact definition is you see the cortical break, but of course you need 2 planes, and if you have only 1 plane, sometimes you need to guess it a little bit more. So did somebody see anything here? Any comment? No comment. Okay. So what I can see, if you compare the MCP joints, I see this third MCP joint that looks not good, because here we see there is some small osteophytes that are not there in the opposite hand, on the left hand. So there are some small osteophytes, and there are these cystic areas that are not here. They look suspicious. Also here, there are some maybe smaller cysts. And these findings are further underlined by looking at the calcification. So when you see osteoarthritis at the MCP joints, especially second and third, you need to immediately look at the TFCC area, the triangular fibrocartilar cartilage. And there are some, maybe if you look at it on your device, some faint calcifications. And I'm so convinced, because I now have, of course, a follow-up. So this is the right side, and this is the right side after 3 years. And what we can see in the third MCP is even more joint space narrowing, larger osteophytes, larger cystic changes, all the cystic changes over here. And in the TFCC, we now have very severe calcifications over here. And this makes a diagnosis of CPPD. So that's a CPPD case with manifestation at the TFCC and the MCP joint. So I wrote everything down here so you can read it after the session. And these cases are available to you for the next 7 days. Any comments? Third MC, Yasmin, you have done it right. Third, metacarpal, very good. Okay, next is case number 3. Case number 3, mild symptoms, but severe foot destruction. Let's check it. So there's no follow-up here. It's a woman, 65 years of age. She has psoriasis. And the first presentation to the rheumatology clinic was after she spent many years in the orthopedic, doctor who treated her with different types of medical help and also did some operations. Currently only mild symptoms, but still she's now seeking the advice of a rheumatologist, and B27 is positive, as it is frequently the case in psoriatic patients, but there's no CRP elevated and also no rheumatoid factor. So my advice is, if you have a medical history of psoriatic skin manifestation, you should take at least one more closer look compared to a patient who just has joint pain to search for erosions and periosteal reactions. So I didn't have time to prepare the MCQ, but let's go to this. Actually, I prepared it. Somehow it's not visible. Let's see if I can make it visible for you. No, I forgot. Okay, so let's do the same. Make first the hand analysis. We need to optimize the contrast here a bit. Yeah, that's better. And then we enlarge it. And as soon as you see something, please write it into the comments. So DIP joints. So psoriatic arthritis is affecting the DIP joints. So this patient is 65 years of age. Of course, she also can have osteoarthritis. This makes it especially difficult for us to distinguish osteoarthritis of the DIP joints from psoriatic arthritis of the DIP joints. But if you look at this joint, you see there's some sclerotic rim and some asymmetric joint space narrowing. So I would say this is osteoarthritis. These joints, they look good. And here on the other side, we see some osteophytes, joint space narrowing. So I would go for osteoarthritis here. Then we look at the PIP joints. Look good. Here, maybe not. You can write it into comments if you see something on the PIP joints. Then we have the MCP joints. They look nice. MCP joints look good. No cystic changes, no erosions. And then also we have the wrist. And the wrist tells a story. So we have joint space narrowing, but it's a special type of joint space narrowing. So please take your comment, your chat box, and give some comments for me so I can be happy. Please, Imane, Yasemin, try to analyze these images. I will start screen sharing again. So here's the screen. Here's the screen. And it's even better to be seen if you log in. Okay, so what's about the PIP on this fourth? Wait, is there something strange here at the PIP on the right side? So this is an arthroplasty of the PIP joint. So we see there is this shape over here, and the similar shape is here, and then the joint space looks wider than it should. So there's no normal joint space here. So that's a silicone foreign body that was placed into the joint, and that's called a Swenson endoprothesis or Swenson arthroplasty. That's done in patients with osteoarthritis or arthritis to maintain the alignment of the joint, and that's something that orthopedic hand surgeons are ready to do. So they drill holes into the bone, place these spikes in, and this is all one body made of silicone, and it bends a little bit, so it keeps the joint aligned. So if you have a joint that has a subluxation, and then you insert this prosthesis, you have a nicely aligned joint again, and quality of life has improved. So that's a Swenson endoprothesis. I will Swenson endoprothesis. Don't know if you can see this. I think no, it did not go through. And then the next is the wrist, because at the wrist, there are several things that are not right. You see the joint space between the lunate and the radius is normal on both sides, but the joint space between the scaphoid and the radius is not normal. So this asymmetric joint space narrowing is a sign for early crystal arthropathy. So patients with this type of joint space narrowing may develop crystal deposition in the TFCC later on. Also, it is a sign that the scapholunate ligament is torn, which is also happening in CPPD, but also in some cases of rheumatoid arthritis. And maybe there's some cystic area over here. And of course, the ulna is too long. We have ulnar positivity, so we have like 4 to 5 millimeters of advancement of the ulna, which is not good. So again, you can read this here in the final text. But before we do this, we look at the feet. And hopefully you see what's going on with the feet immediately. Can you see it? So what's going on with the feet? It's a patient, 65 years of age, with psoriasis. So does she have psoriatic arthritis? What do you think? I would say yes, because you see interphalangeal joint, distal interphalangeal joint, proximal interphalangeal joint, but here, no joints, no joints. And even this bone should look like this one. It's atrophic. So this is a pencil and cup deformity, a mutilation that we see in psoriatic arthritis. Also here, this joint looks not good, and we also have a similar destruction over here. So these are 3 toes, the fourth on the right and the third on both sides, that are affected by psoriatic arthritis. And in fact, it's arthritis mutilans. It's a mutilation or pencil and cup deformity. And is there a second finding that you would like to discuss with me? Yeah, very nice. I only have experts here today, pencil and cup on the third ray, but also on the fourth one. So anything more? There's more comments. Andrea, very nice. So look at the images and try to find one more finding. Don't you think that the fifth ray also has some problem over here at the MTP? So look at the bone, how there's something missing. So usually you have this nice cortex going all around, And here there is this irregular contour. Also over here, there's something that is not there. Also here, see it. So there are symmetric erosions on the MTP joint of the fifth ray on both sides. So it's a patient with psoriatic arthritis, mutilating changes. I did exact description on what we see on the hands and on the feet. All right, already the third case. And now we can go to case number 4. And before we do that, I need to check how many of you are in fact on the platform. We have 10 people who have logged in. So we can expect some answers now. All right, let's start with case number 4. So case number 4 is a 50-year-old woman with unexplained hand and foot arthralgia. She had intermittent pain and swelling in the fingers and toes, and also previous episodes of morning stiffness, and also has psoriasis. B27 is positive, CRP is even elevated, and rheumatoid factor and anti-CCP antibodies are negative. All right, so we know this. Now we compare first the hand X-rays. And you can do it yourself. You can look at the hand X-rays. Next, you look at the X-rays of the feet. And then there's this question here that as many of you as are logged in can please answer. Meanwhile, I will continue with explaining these X-rays for those who are not in the mood for a quiz game. So here we have again the analysis of these X-rays. We see the DIP joints have normal joint space width. They have no erosions, no osteophytes. There is maybe some small calcification over here. This should not be a reason to say this is systemic scleroderma. Can also occur in osteoarthritis. Maybe there's a little bit swelling of the soft tissues here, but this is not a good sign. You see there's no osteopenia. The PRP joints, they look good. We have the MCP joints. And if you compare MCP joints, so this is the sesamoid. This is the fourth, the third, the second. So I would say there's some small cystic area here in the third MCP joint and maybe here. But I would not make any conclusions out of it. I would just write it down. And then looking at the wrist, we can see it's all looking good. Maybe joint space between the lunate and the scaphoid a little bit extended. Maybe also smaller cysts, but no calcification. So I would say this is more or less a normal hand X-ray, except these cystic changes here on the left side. Now looking at the feet, the question is, please take a closer look at the left foot. And we already have 2 answers. We have 2 of you who have already answered. Nice, that's nice. The others can still do it. So if you compare, and again, you need to enlarge. So you see that's the right side, the left side. And if you compare the right distal phalanx of the big toe with the left one, you can see at first there's some soft tissue density here. Maybe it's here as well, but it looks a little bit more pronounced on this. This looks good, but here maybe. And then you see this irregular spikes at the distal end of the phalanx. Also, if you compare the pattern of the spongious bone, this looks normal. But here we have diffuse sclerosis, and there are irregular cystic areas over here. So this is, I would say, some manifestation of psoriatic arthritis on the big toe on the left side, but not on the right side. And the question was, what do you see? And the correct answer was the big toe only, not the other toes. And thank you for the one person who ticked the last answer. So I don't think that there are periosteal reactions also on the other toes. Of course, it's also a matter of debate, but I would say the first toe sticks out here. So this is a patient with psoriatic arthritis with periosteal new bone formation, especially at the left great toe. And you can read it up here. So let's take a closer look at our last case. In the last case, we are dealing with a patient with load-dependent radial wrist pain, so more or less close to the thumb. And it's a 63-year-old woman with rheumatoid arthritis diagnosed early, and she was treated at an external department for rheumatoid arthritis for quite some time. Even had 5 biologic agents who all did not help so much. So now she's changing the treating rheumatologist to seek help. Maybe here we could speculate about periarticular osteopenia. I would say that that's in the range of possible interpretations, that there's some joint-related osteopenia over here. The question is if these are leading to the evidence of arthritis. And also I have prepared a question for you with only 4 answers. So I would be very happy if you could look at the images yourself and come to your own conclusion before I continue explaining the case. Meanwhile, I will check the comments, but so far there's no new comment. All right, so those of you who are just watching and waiting for my explanation, maybe if you use the chat box to write where you are from which country, which city, that would be nice. So let's have a look here at this 5th case. Again, it's important to enlarge. 65-year-old woman. The joint spaces here at the distal interphalangeal joints, they are maybe a little bit too narrow. So that could be a sign of early osteoarthritis, although there's no big osteophytes, no cystic changes, no sclerosis. So I would not emphasize this in my report. Same for the PRP joints. They are narrow somehow, but looking uniform in all the joints. Similar for the MCP joints, there's no cystic changes here. That's one of the few cases with normal MCP joints. And then looking at the wrist, we see the CMC joints over here, also CMC joint 1, which is usually affected by osteoarthritis. And then we have the radiocarpal joint, looks nice, no joint smooth narrowing. We have the intercarpal joints here, except this joint. And this joint is called the STT joint, the scaphotrapezoid trapezium joint, connecting these 3 bones. And that's a case where we have an isolated osteoarthritis of this joint without concomitant osteoarthritis of the CMC1. Because usually in a case with severe osteoarthritis of the thumb, you also have secondary osteoarthritis here. But this is a case where we have just osteoarthritis in this single joint. And 2 of you came to the correct conclusion, and the other one were tricked by the maybe osteopenia here and voted for rheumatoid arthritis. So in my opinion, CMC osteoarthritis is not the case. It's STT osteoarthritis. And if you didn't know this kind of disease, now you know, and now you can write it into your reports. All right. So this was the spectrum of cases that I did prepare. Actually, I had 3 more. But I skipped those as I was not ready describing these cases. And I hope you liked this session. if you are having your own difficult cases, would like to tell you about our new service that is called Open Cases, and it's the URL of opencases.net. I will write it into the I will write it here so you can use it in case you have it. So opencases.net is a free service that you can use to share cases. So you can create an account, you can upload your cases, you can store your cases. It's similar to other services like Paxbin, and you can store the cases, and you can also share the cases with links that are auto expire after 30 days. And then you can ask your colleagues about their opinion. Even you can collect the comments in this case, and I invite you to try it out. Otherwise, please follow our social channels on BerlinCaseViewer, on different platforms like LinkedIn, Facebook, Instagram. We even have a TikTok. And it was very nice sharing time with you, and I hope you learned a lot. And let's see if somebody wrote where they are. The young Bucharest from Romania. Very nice. That's very nice to see you here. All right. So see you at the next occasion. Maybe in August we're doing another session on subtle findings, then maybe on MRI of the sacral joints. I'm not yet decided now, but please stay close to our social channels and to our email list, as I will announce it over there. So thanks for watching, and bye-bye.